Okay, everyone, let's go ahead and get started and give everyone time. Today's a special day. We're celebrating one of our giants in cardiovascular medicine series and really celebrating Dr. Larry Cohen, who's here with his lovely wife, Jane. And we have a wonderful speaker who I think I'll introduce in a minute. I'm doing double duty today, so I'm going to make a few comments. First, just remind everyone, please apply for CME credit, and that these are the next, the upcoming lectures from Jennifer Frampton next week. And then we have some fellow presentations, a faculty meeting, and then a few visiting professors coming from international as well as national. And then just to remind everyone, we take no support for our grand rounds, and there's going to be, as our visitors know, there's probably going to be 40 or 50 people online eventually, but a nice mix of people here in-house, and we'll go from there. So before I introduce Jerry Bloomfeld, I just wanted to make a few comments about who we're celebrating today, which is Professor Larry Cohen. And I've really been one of the highlights of my time here is to get to know Larry and Jane, who've been so generous with their time and their friendship to me personally, and I know to many of you here. Just to kind of give you a sense, and it won't go into great detail, but the impact that Dr. Cohen has had in the lives of cardiology at large and at Yale. And I'll make some links, and you'll figure out the links. So Larry is a 1950 graduate of Midwood High School in Brooklyn. Remember that. We're going to come back to that, okay? And when he graduated, he went off to Boston at Harvard, where he did his undergrad before doing his medical school training at NYU. He then did his internship here at Yale New Haven Hospital, and his relationship to Yale really was cemented, I suspect, at that point. Finished his residency, and then was, and I get these pieces a little, the years maybe off a little bit, did a series of different things before he came back as a senior assistant resident at Yale New Haven, which first he spent a few years as a research fellow at the Peter Bent Brigham, where he did really very important work with Richard Gorlin at the time, and investigated the role of beta blockade, among other things. He also, before that, I believe, and Larry, you can correct me, before that, I think was a commissioned officer within the U.S. Public Health Services. And so when you look at Dr. Cohen's CV, you see the first 7 or 10 papers are about Staphylococcus aureus or infectious syndromes before he got really deeply into major mechanisms of clinical cardiology and really cemented himself as an investigator in clinical cardiology. After his time in residency, he went off to the clinical service at the NIH, where he was worked with also with Dr. Braunwald, papers from that era to highlight really are just investigating the role of beta blockade to support the treatment of ventricular arrhythmias, and as well as expanding our understanding with that group of what was called then IHSS, which we now know is hypertrophic cardiomyopathy. So critically important work before he was recruited from the NIH to UT Southwestern, spent some formidable and formative years there. And then we were very fortunate to recruit him back to Yale as chief of cardiology in 1970. And then spent 8 years as chief of cardiology before he took on increasing additional administrative roles in the dean's office as part of the regulatory infrastructure for research, and also during all that period here at Yale, really, I think, started our clinical trials work in cardiovascular, doing a lot of the TIMI studies, being an important member of the CAS registry and other important fundamental clinical trials science of the era. So, so really a giant in cardiovascular medicine, multiple leadership roles in societies, the Association of University Cardiologists, the Interurban Society, among a few, and important roles within the American Heart Association, as well as the American College of Cardiology, in clinical cardiology along the way. So we're here really to celebrate Larry and Jane, and really thank you for all you've done for our field and for us here at Yale over these many decades. Here, I think I want to say it was 55 years. Is that right? Did I do the math right? Here at Yale. Yeah, 55 years at Yale. So before we introduce Jerry, I just want to give a round of applause. So now trying to make the link back, 43 years later, Dr. Blumfeld graduated from the same high school, Midwood High School in Brooklyn, before he went off to Princeton, where he did his undergraduate degree, and then went to Hopkins, where he did his medical school degree, also getting an MPH. And then we were fortunate to recruit him when I was enrolled at Duke University as a trainee in cardiology. He was an assistant chief of service at Hopkins, so we got him back and forth, I think, for a year, as they are wont to do. And then we recruited him onto our faculty at the completion of his training. Jerry really helped us establish, and really was the poster child for interests, investigative, clinical, and educational interests in global cardiovascular health. And in fact, wrote what I think was Mark Huffman at the time, and there was a group of 3 or 4 of these kind of leaders in global cardiovascular health, particularly focused on non-communicable diseases, that were setting the stage for this field, in the era. And it really, I think, a testament to him to see as it is evolved from its inception. Jerry was also able to launch a clinical program, an educational and investigative program that we led together funded through the NIH in Kenya. And a lot of his research, which I'm sure he'll share with you, emanated from that. He's been the recipient of not only Fogarty Training Awards, but also Career Development Awards for the NIH, and has multiple R1s looking at not only rural health, but the way we task shift clinical care for HIV patients. And so without much further commentary, I'm sure he'll share with us what he's done. Really a pleasure to have Jerry visiting with us. So thanks, Jerry.
Thank you, Eric, for those very kind words. It's really an honor to be able to speak with you this evening in honor of Dr. Larry Cohen, or Dr. Larry, as we've agreed that I'll refer to him as, someone who's been inspirational, certainly to many of us in the room, and to even those of us from afar who haven't had the pleasure of training at Yale. It's an honor to be here and to present this talk, and welcome Jane as well. It's really great to spend some time with you guys last evening. What I'd like to do for the next few minutes here is talk a little bit about global as local, or global is local, building off of some of the work that I've been able to be involved with, some initially under the mentorship of Dr. Velasquez. But I want to really focus in on some of the findings that I've been involved in that really changes how we as cardiologists think about our patients, particularly those with HIV. these are my disclosures. And in grand rounds fashion, I thought it was appropriate that we start with a case. After I delve into a case, I'll talk a little bit about our Cardiac Center of Excellence in a developing country, and then really build off of that to talk about two studies that I've been fortunate to be involved with that both relate to people with HIV. But this is a case of a 74-year-old woman who had dyspnea for 4 days. She was unable to afford her medications, and so she's not been able to take them, and she sees us in clinic. She has a past medical history of a dilated cardiomyopathy that was only diagnosed 5 years ago. She has a history of hypertension and atrial fibrillation. She's a farmer by trade, and she's still very actively farming maize, corn. She's supposed to be on Lasix, digoxin. We still use a lot of that. Carvedilol, enalapril, but does not recall being on an anticoagulant. Seeing her in clinic, mind you, her blood pressure is 79/43. She's in rapid atrial fibrillation and hypoxic with a antikypnic. On exam, her PMI is laterally displaced. She has an S3. You hear TR and MR murmurs. Her jugular venous pressure is elevated, and she has gross bilateral low extremity edema. She has crackles in the bases. So this is clearly someone who's presenting in shock, likely related to her cardiomyopathy. So of the exams that we would like to perform in clinic, she is financially limited. And so of all the things we'd like to do, we decided that the best way to spend her money would be to get an echocardiogram. And this is her echocardiogram that's performed that same day. This is the parasternal long axis view. You could see we're dealing here with a dilated cardiomyopathy with a severely reduced ejection fraction. Here's some other views that show a little bit of her mitral regurgitation, her global hypocontractile pattern that appears to involve both ventricles and severely dilated atria, all going really concordant with her known history of a non-ischemic dilated cardiomyopathy. So here we have a patient presenting with an acute episode of decompensated heart failure. The only rub is that she doesn't happen to be at Yale New Haven Hospital or at Duke University. She's in a low and middle income country. She's in Kenya, where the GDP is about 2,000 GDP per capita per year in comparison to 81,000 in the US. There are 47 million people in Kenya, 25% of which are living below the poverty line, of which she certainly is included there. And she presents to our hospital, and these are some representative pictures of the hospital that she is found in, and the hospital that Dr. Velasquez and I started working in around 2008, 2009. And you'll notice that we don't really see oxygen available at the walls. We see multiple patients. This is really a ward, multiple patients on the ward. The top right picture is a picture of rounds. The bottom right picture is a picture of two patients sharing the same bed, and that's not by choice. The hospital at this time is about 120% capacity. And so often patients, some admitted with advanced cardiac disease, some admitted with other medical conditions, would have to share a bed. And so imagine trying to take care of a patient with acute decompensated heart failure who needs all of the medications and bells and whistles that we're used to here, but not really being able to deliver it at an acute care hospital in Western Kenya. I'm going to return to how this case ended out, but I did want to paint this as we telescope out to look at this issue from a global scale, that we know that globally cardiovascular diseases, including ones like this patient had, remains the leading cause of death worldwide. These are data globally from across all ages, especially as you get into older ages, that cardiovascular disease is the #1 killer. This is also true in low and middle income countries, or LMICs. The graphic on the left shows the change in rates over time, with 2019 being the most recent year. These are deaths per 100,000. That even in low and middle income countries, as we've made progress in the care of HIV and other infectious diseases, cardiovascular is the largest chunk of deaths per 100,000. And of those cardiovascular diseases, I'm sorry, of those non-communicable diseases, which are shown in blue in the figure on the right, cardiovascular disease accounts for the largest proportion of non-communicable diseases in low and middle income countries. Now, what's interesting is that we have many more cases of cardiovascular disease in more developed countries. But the difference is the differences of mortality. So when we look at the age standardized death rate globally, we can see that in the lighter colors, the reds, the yellows, and the light blues, that the age standardized death rate, which accounts for the younger age of the population in LMICs, the age standardized death rates are higher in what we would consider low and middle income countries. This is a problem today. It's also forecasted that this will continue to be a problem in the future. This is a projection looking at the change from 2015 to 2040 and the percentage of disease burden due to non-communicable diseases. And what the graphic shows here is that in the countries that have the lower health system capacity index, or I should say it's a higher number, but a poorer health system capacity, that's the x-axis. And the change in the NCD burden is on the y-axis. And you can see that those countries that have the least equipped healthcare systems are also the countries in the poorest regions of the world, and are also expected to have the greatest increase in non-communicable disease burden. As if that weren't enough, we also look at the healthcare personnel that are available to people dealing with non-communicable diseases in low and middle income countries. I'm showing here a snapshot from Kenya. This is the distribution of doctors per 10,000 by country. And I've shown you here where Kenya is on the map and where the USA is on the map at about 2 and 26 per 10,000. Realizing that the World Health Organization recommends that you have about 10 physicians per 10,000 for a well-functioning healthcare system. So with this as a backdrop, I'd like to share with you one example of how our group at Duke, now about 16 years ago, responded to this particular crisis, looking specifically at an example from Kenya and how we developed what we call our Cardiovascular Center of Excellence. I'll start with a little bit of a summary in mind. We had the opportunity to summarize some of our work led by Dr. Velasquez and a number of individuals. I was a fellow at the time, a senior fellow at the time. Summarize our work of how we build sustainable capacity in the public healthcare system in Kenya. And this central illustration really highlights that we had a multi-pronged approach. And unfortunately for time, I won't go into every detail of all of the aspects here. But realizing that there was a heavy disease burden and a lack of well-trained personnel in Kenya, and an opportunity from the National Heart, Lung, and Blood Institute to train a cadre of physicians and other ancillary personnel who would confront cardiovascular disease, we hired and trained a robust cardiac team. We had efforts to to provide new equipment and supplies, improve health service delivery and create systems, and with an eye towards long-term sustainable financing. Now, how this program started is an interesting story, and I've shown some references here. We start actually with a global partnership for HIV in primary care. There is a well-known program called the AMPATH program, stands for the Academic Model Providing Access to Care, led by Indiana universities. And AMPATH is a consortium where a number of North American universities partner with Moi University and Moi Teaching and Referral Hospital in Western Kenya for the care of people of Western Kenya. AMPATH started about 30 years ago, and they were initially known as an HIV care program. But as those people with HIV started to develop diseases like our case presentation and other diseases, they realized that we needed to expand this consortium. And so the consortium, again, leverages the power of multiple academic medical centers, AMCs, to bring to bear the strengths that we have at places like Yale for service, education, and research. We build counterpart relationships. There's a bidirectional exchange of trainees. We work for mutual benefit from our respective universities, all towards an idea of health system strengthening. And as AMPATH wanted to expand into cardiovascular disease, we identified an opportunity at Duke to join the consortium and to lead in the therapeutic area of cardiovascular diseases. This was a program that the NHLBI and United Health partnered to fund called the COEs, or the Centers of Excellence. There were a number of these around the world. We were fortunate to partner with two, one in Kenya and one in China, but I'll focus on our work in Kenya. As I think about lessons to take away from this program, I think this might be one of the most important ones to summarize how we approached developing the Center of Excellence in Kenya using the WHO Health System Framework, where we identified the important system building blocks. Again, we could easily come in and treat a number of patients and do good work, things that would last and be impactful to people, but we really wanted to build a system that might outlive our own efforts. So we focused on these system building blocks of service delivery, thinking about the workforce, information systems, medical products and technology. We spent a lot of time on financing. We invested heavily in developing leaders and governance, all to improve access, coverage, quality, and safety of care to reach these overall goals. There were a number of milestones in this program. This program started in 2009, co-led by Dr. Velasquez and Dr. Kimayo, Dr. Kimayo's Kenyan counterpart. A number of milestones here. And I could easily spend the rest of the time just with pictures of Eric doing all types of things in Kenya, training folks and doing echoes. These are some of our major milestones. There's a story behind each node on this timeline. But I thought one way to summarize this is to highlight just a couple of them, that we really wanted to focus on locally driven and locally relevant mentored cardiovascular disease research, where the trainees in our program were Kenyan internal medicine residency trained individuals who wanted to focus on cardiovascular disease. As we thought about care delivery, we focused on nurses, and as we thought about who would be actually seeing these patients on a day-to-day basis. We developed a cardiology fellowship training program where we brought the teachers to the students for in-country training so that we would move away from issues of brain drain. We worked on curriculum development. We developed inpatient and outpatient cardiac services where none existed before. We brought ACLS training to the unit, which was actually led, our first training was led by Dr. Velasquez. We focused on cardiac diagnostic expansion. I mentioned the unit and really focused on a place to deliver advanced cardiac care in a CCU. A picture is worth 1,000 words, and I think it's appropriate to show a few pictures here. I don't think the mouse, maybe it does translate. This is in 2009. Here's Eric at our kickoff meeting. I think we were all very jet lagged actually on this day. We had just walked into this meeting with Dr. Kimayo, Joe Mamlin, who's the father of the AMPATH program. This is in 2009. And here I just show a number of pictures of some of the capacity building that we've been engaged with, some of our partners that we've brought over from a number of universities. I highlight some of our nursing leadership. I found this slide from 2011. We were 2 years into our program. We had really just started our inpatient and outpatient services, but being the visionary that Dr. Velasquez is, we foreshadowed and said, well, what would be the phases of expansion? Eric, I don't know if you remember this, these slides, but we talked about various phases and said at some point we would actually be dealing with a cardiac unit and a cardiac cath lab. Well, fortunately, we were correct, and some of the pictures here are actually of our new cardiovascular care unit, which was inaugurated in 2013. Many of these efforts due to a number of individuals, again, who I could spend many hours on. But I want to get back to the case. So remember, we had this 74-year-old woman who we're seeing in clinic who comes in with acute decompensated heart failure. She was actually our first patient admitted to our cardiac intensive care unit. We brought her in. We were able to give her IV Lasix as she needed. We gave her dobutamine via an infusion pump. That sounds mundane, but being able to use an infusion pump in this hospital was a leap in care, as opposed to counting drips as they drip from a bottle. Has anyone had to work in a situation like that? Okay, a few people. I've been there too. We had multiple vital signs over 24 hours. That sounds mundane. That's also a feat. We eventually got her stable enough to reinitiate vasodilators. We worked on social work to make sure she could afford her medications. And she came from a ward that looks like this, and she spent her time in our nascent unit. And then it was time to transfer her back to the floor, or so we thought, because she absolutely refused. And she said, I'm not going back to the unit. There's no way I'm going back there, because there I will die. And we didn't disagree with her. And so that actually set up a model whereby, nowadays, most of our patients, when they're admitted to the unit, we're taking care of them until they're stable to go home, although we're also working on the general ward environment as well. Part of the ethos of the program was always that this was never going to be a sustainable program if it relied on input, heavy input from Duke ad infinitum. And so in 2018, we had a dedicated effort to make sure that we had a thoughtful transition to Kenyan leadership. We work with Moi University, and this is a screenshot from their announcement in 2018 about their next intake for their postgraduate programs. And for the first time ever in the country of Kenya, there was the option here, number 5, to apply for a clinical fellowship in cardiology. Again, run and administered and financed and logistics managed by Moi University, with Duke attendings as partners and educators. This gentleman shown in the middle picture, he's one of our early trainees. That's Dr. Barasa, who was a fellow of Eric and I, who is now the head of our unit, who I report to when I'm in Kenya, which is really fun to do. In the spirit of transition to leadership, we've also seen some other early fruits of this labor. And again, the goal was always in-country leadership. And in this case, we actually identified early on this gentleman shown here in the bottom left. This is Dr. Titus Nyeno, who is a medical officer, or a house officer, basically, that we were working with in 2009, who had aspirations for US-based training and is an excellent physician and an excellent colleague. These are pictures me and under Eric's tutelage early in our program, getting some mentorship out walking in the fields of Western Kenya, and Titus around that time as a medical officer. And those initial seeds that were planted have started to blossom. Here is a more recent picture of myself and Titus, introducing him to some regional collaborators who want to know more about opportunities to partner with Moi University, such that in 2024, Titus, who's originally from Kenya, came to Duke to do internal medicine residency, finished cardiology fellowship at Duke, and is now on faculty at Duke, is now the face of our Duke Kenya partnership and our Kenya partnership site lead. So really this idea of in-country leadership on both sides of the ocean. Where has this program landed today? Well, here's the state of Moi Cardiology currently. There are 5 cardiologists on staff. There were 0 when we started. 4 fellows have graduated from this program and 4 more in training. I've mentioned Dr. Nyeno. We have a cardiology and echo certificate program, of which there are 11 trainees currently. We've now embarked on surgical valve replacement camps that are happening monthly. And this bottom right picture is a picture of that cath lab that we envisioned 16 years ago, the cath lab that is in the process of being unboxed last month. Me standing with one of our recent fellow graduates, who is our clinical lead in the cardiology division. I'd like to share a little bit of our research agenda, and I'll I put this slide up just to share with you the breadth of the locally driven questions that we've asked over the years. Everything ranging from air pollution and cor pulmonale to atrial fibrillation and other arrhythmias to HIV and heart failure. So I'm going to focus in on one of the studies that we initially led that was actually the subject of my K Award many years ago. But the backdrop being that we know that there's a syndrome of heart failure and that it was common in Kenya, and that historically the etiology seemed to be distinct, where coronary artery disease and ischemic heart disease seem to be exceptionally rare. And our experience led us to think that maybe that had changed, and the epidemiological research at the time was pointing to an increase in cardiovascular risk factors. With the idea that we would look for markers of atherosclerosis, again, this is pre-cath lab or any other advanced imaging that might show us a coronary artery disease. We looked for markers of atherosclerosis in a middle-aged population of people with and without heart failure. Our markers of atherosclerosis, we looked at a wall motion score index, we looked at ischemic changes on an ECG, and an ABI that was less than 0.9. And we said that if someone with heart failure had all three of these things, there was a good chance that perhaps the heart failure was related to ischemic heart disease as well. So two major findings from this study. Number one is that we found that non-invasive markers of atherosclerosis were actually quite common, more common in people with heart failure than without. Here we look at the individual odds ratio for each of the abnormal echo with wall motion score index, ABI or ischemic ECG, more common in patients with heart failure compared to without. We also wanted to look at the sum of the markers, and very few people had more than one, and I acknowledge that. And so the confidence intervals for all three is quite wide and not something I would put a lot of weight on. But nonetheless, I think the trend shows that there was more ischemic heart disease than the literature had reported. And when we actually adjudicated heart failure etiologies using an adjudication system commonly used in the sub-Saharan Africa context, what we really found is that there was a broad array of causes of heart failure in this region, both idiopathic dilated cardiomyopathy, ischemic heart disease. But we go back to the fact that we were working within an HIV care program, and there was a decent proportion of individuals with HIV and heart failure that sparked another line of research and investigation. So from there, I'm going to bring the global and these issues related to HIV and cardiovascular disease and bring them a little bit more local, and then hopefully round out and see how the two interact. So I'm going to talk about some of the lessons from global care and how we can apply them domestically. And I'll first start with lessons from the REPRIEVE trial, which I'll explain here in more detail. We know that HIV we've made tremendous gains in how we treat HIV globally, due in large part to the PEPFAR program, that the number of deaths and incident cases of HIV globally have gone down, thankfully, due to widespread access to antiretroviral therapy. Prevalent cases continue to rise, and that's sort of a blessing and a curse because patients are living longer with HIV, and so we have more prevalent cases. When researchers have looked at the causes of death in HIV, it's changed dramatically over the years. These data are as of about 2016 or so. And you can see that the ranking here is actually ranked according to the standardized mortality rate from highest to lowest. That cardiovascular disease and stroke as a group of conditions actually ranks fairly high in terms of mortality in people with HIV. Of that mortality rate, ischemic heart disease and myocardial infarction is well known to be much more common in people with HIV compared to without. I'm summarizing a lot of literature here. This is a slide from my colleague, Dr. Markella Zani, who summarizes this well, that if you look at North American and European cohorts and compare the risk of myocardial infarction to people with HIV compared to people without HIV, estimates are that it's about 1.5 to 2 times greater in people with HIV. Now, note that I mentioned these are North American and European cohorts. And if you're thinking about HIV and any of the communicable or non-communicable diseases that are comorbid with HIV, you can't ignore sub-Saharan Africa. It's where we have the highest prevalence of HIV globally, the highest incidence. This is true for women. This is true for children. But not only is HIV quite common in sub-Saharan Africa, we also know that cardiovascular diseases attributed to HIV are much more common in the region as well. These are data from Anoop Shah and colleagues published a number of years ago, where he looked at the disability-adjusted life years that you could attribute to cardiovascular disease in people with HIV and how that played out globally. And what you see here in the darker colors, which represent Eastern and Southern Africa and Asia and the Pacific, that the cardiovascular DALYs due to HIV are increasing from 1990 to 2015, maybe a little plateauing, but that the regions where heart disease and HIV is the most pressing are actually in these LMIC regions. In response to this, the high MI rate in HIV, the global burden, the American Heart Association, this is in 2019, I was fortunate enough to be part of a scientific statement to develop some type of guidance on what we might do in people with HIV, because we've observed this risk for many years. And I summarize a few of the findings here. Number one, that we certainly realize that the risk is greater, 1.5 to 2-fold greater in people with HIV. And although we didn't understand the biology of the process completely, and I can't say that we still do yet, but there are certain risk enhancers like a poor HIV disease control, substance abuse, et cetera, risk enhancers that we should be mindful of. And until we could get more complete evidence, we offered a practical expert consensus approach. And this was published in 2019. I won't show you the approach because very shortly thereafter, we actually had the data that we'd been asking for. So that approach is a little obsolete at this point. But these are data from the Reprieve trial. And for those of you who aren't as familiar, this is a global placebo-controlled randomized trial of pitavastatin, a moderate intensity statin, compared to placebo in people with HIV who otherwise do not meet criteria for a statin. So these are people with low, and I'll show you the details of the enrollment criteria, low predicted ASCVD risk, randomized to pitavastatin for placebo, a planned follow-up for 5 years. There is a coronary CTA substudy, so we think of as a mechanistic substudy to actually look at changes in coronary plaque, powered for these endpoints, cardiovascular death, MI, et cetera. Now, the global local link here is that Reprieve was designed as a globally representative trial. And anyone who's been to any of most of the major cardiovascular RCTs at the meetings, you realize that the map that is shown of where enrollment happens, usually Africa is either the dark or the light continent because we have no enrollment from the continent. So we're really proud that of the total enrollees in Reprieve, we have about 15% of total enrollees from sub-Saharan Africa, clearly most of them from high-income country regions, but really a globally representative trial. Here are the baseline characteristics of Reprieve. What I'll show you here is separated from the pitavastatin arm and the placebo arm are really just the overall profile, sort of about 50 years old. I'll call your attention to the bottom few rows. Very low atherosclerotic, this is by the PCE equation, low ASCVD risk, 4.5%, and LDL levels at that level that wouldn't qualify for a statin otherwise. This study was published late last year. Here are the key primary and key secondary endpoints. After about 5.5 years worth of follow-up, 36% reduction in the first MACE event compared to placebo, and about a 23% reduction in MACE or death compared to placebo. A highly effective trial that have now translated into guidelines from the ACC, AHA, HIV Medicine Association, as well as the UK HIV guidelines for an indication for statins for people with HIV at otherwise low ASCVD risk. Clearly, the trial was not designed and powered to analyze the differences in all of these subgroups, where there's a very consistent effect across major subgroups. There was no treatment modification based on CD4 count or viral load or any other HIV characteristics. And the findings were generally consistent across the global burden of disease regions. Those were the regions of the world that were included: Latin America, the Caribbean, South Asia, Southeast Asia, and Sub-Saharan Africa. The effect of pitavastatin on the primary outcome was larger and outsized from the effect you would expect on LDL lowering. So there was about a 0.8 millimole per liter difference in the treatment group in REPRIEVE. That's about how much LDL was lowered. And when you extrapolate to what you would expect for the MACE that you would prevent based on LDL lowering, which is shown here in this line of unity, you'd expect that if you had a 0.8 lowering of LDL, that you would achieve a 17% reduction in MACE. However, in REPRIEVE, we saw an outsized effect that was much greater than what we'd expect from LDL lowering alone, suggesting that LDL lowering is not perhaps the primary way that statins are saving lives in people with HIV. Well, this brings us to the sub-study where we actually looked at some of the potential mechanisms, and we asked about non-calcified coronary plaque, soft plaque, vulnerable plaque. What was happening in plaque in this group? And we had about 600 individuals who had CTAs at baseline and at 2 years. And what I'll call your attention to is the change in baseline in non-calcified plaque, that we actually decreased the size of soft plaque, non-calcified plaque in the pitavastatin arm compared to placebo. There was also less progression of plaque. We preserved progression by 33%. And with mixed reductions or reductions in some of the lipid-mediated inflammation, but not much change in HS-CRP. Now, REPRIEVE being a global trial, we've also asked ourselves, well, how well are we predicting risk around the world in people with HIV? And what we did here is that we relied on prior literature that showed that when you look at the best risk predictors for people with HIV, of all the various risk scores that we have access to, it's the Framingham and the pooled cohort equation that had the best discrimination to date, with an observed to expected ratio flirting around 1.0, 1.1 being exact. There are some limits, obviously, to the Framingham and to the PCE equation because they're not derived or really validated globally, and they don't have HIV inputs into the equation. So what we've asked in a study led by Markella Zani and Steve Grinspoon, we asked, well, how well do the PCE and another risk predictor, the DAD equation, how well do they perform in REPRIEVE? And this was just recently published last month. And I'll show you here that what we found is that that the PCE score underpredicts events in women and black men, particularly in high-income countries, that were underpredicting risk using the PCE equation alone in people with HIV, which you can show here, that we have more observed events compared to expected events in the black population and in women. However, in low and middle income countries, which are shown here in panel D, we're actually under-predicting risk. We're actually over-predicting risk in low and middle income countries, such that the PCE equation we're finding is not well calibrated when you apply it to very diverse and heterogeneous populations, including global populations. Dr. Grinspoon and Zani actually propose an improved calibration for the PCE score where you multiply them by certain factors in various groups, which is very compelling. So let me transition now to a different way to look at HIV and CVD care. I've talked about some more clinical care paradigms and LDL reduction and pitavastatin. I'd like to talk a little bit more about the healthcare system approach to HIV, again, leveraging some of the work that we've done in Kenya, specifically looking at referrals for HIV care. And for those of you who read or write and think about the HIV and cardiovascular disease relationship, there are many mechanistic figures out there to choose from. This one is one of my favorites that Keiko Soarma and Matt Freiberg put together over a decade ago, which explains the various biologic, atherosclerotic and non-atherosclerotic and environmental exposures that might lead to an increased risk for CVD in people with HIV. And what I really am struck by and what I really appreciate is this idea of access to care. Because I think we can develop guidelines to treat people with HIV who have cardiovascular risk. But the question is, in whose hands are those guidelines being implemented? Most people with HIV are seeing an HIV doctor. They might not be seeing a cardiologist. And so we asked the question whether or not it may be beneficial for people with HIV to see cardiology specialists. So this is a study that we're in the process of wrapping up that we call the Pathways study, thinking about pathways and specifically healthcare system pathways to CVD prevention and for underrepresented racial and ethnic minorities with HIV. This is a consortium of institutions through using the PCORI common data model. And we basically have cultivated a cohort of about 10,000 individuals with HIV with follow-up from 2014 to 2020, which is a really right platform for research. We've asked many questions. I'm going to share with you just a couple of our initial questions. Number one was asking how commonly, using available electronic health record data, how commonly are people with HIV with elevated CVD risk engaging with cardiology care? And might those encounters lead to different outcomes? This is our overall conceptual framework where we've thought about patient-related factors and healthcare system factors that we can extract from PCORI's common data model. We've talked about the specialty referral pathway and the decision decision not to refer and have an encounter. We look at some intermediate outcomes in terms of healthcare system practices. Are they getting more testing, more EKGs, more echoes? Is our blood pressures more controlled? And looking at events. So to summarize some of that work, we first asked the question, who's minding the shop? Who's taking care of these individuals who have elevated cardiovascular risk, and how often are they seeing cardiologists? So in this subsample, which is selected for those at elevated or at low to moderate risk of about 2,000 individuals, we see that it's actually comparable to the Reprieve risk profile with people sort of in their mid 40s to mid to late 40s with an ASCVD risk of flirting about 5%. So very comparable to the Reprieve group. And what I'll call your attention to is that of individuals seen in 4 institutions in the US South, this is the historic cardiovascular and stroke disease belt, the HIV belt, less than 15% of individuals in that risk category were actually engaging with cardiologists. And of those who did, from the time from a referral to an encounter, it's almost 2 years for some individuals. So I think we really highlight an opportunity to really improve care by thinking of novel ways to integrate care, cardiovascular care. We've also done some work to look at the potential relationships between seeing a cardiologist and outcomes. And this is very fascinating work. It's led by Matt Durstenfeld from UCSF. This has been accepted in JAHA. We looked at the incidence of cardiovascular events and mortality according to whether or not someone has had a cardiology clinic visit and the type of visit. And so you can have a cardiology primary prevention visit, which is shown in the dark blue, or a cardiology what we called a secondary prevention visit, management of a cardiovascular disease in the lighter blue. And we compared that to not having a cardiology visit in the hash red bar here. And what you find, initially we thought this was paradoxically, but if you think about the cohort, that it actually looked like we had worse cardiovascular outcomes for individuals who were seeing cardiologists, whether it was for primary prevention or secondary visits. And I think what's going on here is that it's hard to, as much as we account for Carson comorbidity index and all of the reasons why someone may be seeing a cardiologist, there is a confounding by indication in some ways for people who actually do see a cardiologist. And so we think that just one visit with a cardiologist is also probably insufficient to impact cardiovascular outcomes, and more integrated models of care may be appropriate. So this takes us to how we apply some lessons globally and apply them locally. And I think one of the lessons from this pathway project is pathway study is around integration of care. And at least maybe in the healthcare system I work in, when we think about care coordination, I think we might pat ourselves on the back that we can get someone to a specialist and get them back in clinic. But still, we're dealing with siloed care for the most part. And getting someone back and forth between an HIV clinic, it's not simple. What we do in Kenya is actually we do co-located care for multiple comorbidities. And so we used to have what we called HIV clinics, and we had a hypertension clinic or a diabetes clinic, but they're actually now just chronic disease management clinics where we have non-physicians, these are clinical officers for the most part, non-physicians who are seeing patients with any chronic disease. Here is a photo from one of our initial attempts at this, where this is a dispensary, where instead of just getting antimalarials, you can also get your HIV medicine, you can also get your enalapril, you can also get your diabetes medicine. We've expanded to where now we have a chronic disease center, where we have co-located clinics. And Brianna Osetinsky, who's a health economist, has really helped us understand the impact of these co-located clinics, which are can be cost-saving and also improve outcomes for both conditions. A good friend and colleague of mine, Chris Longenecker, who's at University of Washington, has now adopted this, taking this global lesson and applying it locally in the Extra CVD study, published earlier this year in JAMA Network Open, looking at a nurse-led strategy of coordinated care led by nurses with physician backup, where we're actually decreasing blood pressure and improving LDL in people with HIV. So what I'd like to do now is summarize and leave some time for question and discussion. What I wanted to share with you, and I hope I shared with you, was an example of an investment in global cardiovascular health that advances science and improves access to care, that we've done that in Kenya and learning how to do that better here in the US. The development of our cardiovascular program really leveraged an initial investment with really engaged partners, and we had pretty audacious goals early on, and it's taken a while, but we're actually starting to see the fruit of that labor. Reciprocal learning and innovation across geographies. We've talked specifically about cardiovascular risk management for people with HIV, talking about statins for low to moderate risk individuals and care integration. And lastly, I hope you walk away with this feeling that there is relevance of global cardiovascular health research and capacity building that we can apply to our practice here in the US. So again, I'll thank everyone for your attention, and thank you again for the honor to be the Professor Lawrence Cohen visiting professor this year.
Well, first, maybe ask if there's any fellows in the audience who want to ask any questions first. Not to put anyone on the spot, but if there's not, we can take questions from anyone else. Yibing, you're not a fellow, but we'll let you go first.
I love to be a fellow. Jerry, it's a very exciting talk, very educating for me. So I'm wondering, so from the HIV induced the cardiovascular issue. How could we correlate this kind of virus with like COVID virus? Do different virus introduce similarities or distinct outcome? How could we learn from HIV virus infected patient care to help other kind of virus induced patient care?
That's that's a great question. Should I repeat it, or did we all? The question was about the potential similarities between HIV and its effect on the cardiovascular system and the COVID-19 virus and its effect on the cardiovascular system. I think when I think about HIV, I think about two phases. The sort of AIDS cardiomyopathy, the high viral load, low CD4 count era early in the pandemic, still unfortunately common in many developing countries. That cardiovascular disease presentation is more of an acute, dilated, myocarditis picture, often with opportunistic infections. And then there's a more smoldering phase that we think most of the mechanism in contemporary HIV, and certainly in the US, is due to a low level of chronic inflammation and a number of other pathways that are non-inflammatory related, like collagen deposition and fibrosis. And I think the jury is probably still out. I'm certainly not a COVID-19 researcher, but I think that where we are with some of the acute presentations of COVID-19, some of them, call back to that acute HIV presentation with sort of acute myocarditis and more severe presentations. I think it's a fascinating question to understand what does long COVID mean for the cardiovascular system. But I think we need more time to accumulate data there.
Gary, thank you very much for sharing with us your experience globally and more locally with HIV. My question will be about the first clause of your lecture, the time that you reported from Kenya, specifically the programs and models that you've established when you and your colleagues were in Kenya. So my question is, we often learn more from our failures than even from our successes. And my question would be, in Kenya experience, what programs would you consider to have failed? And if you have had such programs that have failed in Kenya, what have you learned to prevent future programs from failing?
Thank you. That's an insightful question. I'll try to limit my response because we've had many fits and starts and failures. I think one of the initial learnings that we had was with our cardiology fellowship training program in Kenya. Many of us in the room, when we think of a cardiology fellowship program, we think of someone dedicating 110% of their time to being a cardiology fellow, and you don't have many other established competing interests, professionally at least. And that's just not the case in many developing countries. Certainly wasn't the case in Kenya, where we had to learn and understand that because individuals were paying for their advanced training, they also had to be employed to be able to afford their advanced training. They certainly weren't paying us, but the systems that they work in within Kenya. And so we had to come to a level of equipoise and calibration in terms of how much access we had of our fellows for this curriculum. And that was a lot of angst, a lot of sometimes tempers and frustration. But that, I think, to your point, that's part of learning. And so nowadays in our fellowship, we have a much more sober and informed approach on how we can engage with our cardiology fellows effectively in Kenya.
Thank you.
Thank you.
I'll maybe ask the next question, and then Jeff will go and we'll take some from the room. So you, very interesting to see Reprieve, report out and, obviously congratulations for your roles in that study and the work that's coming out from that. So, I read CVs and I I saw Maron here somewhere, and I know Maron, maybe when he was training under Dr. Bender, explored the pleiotropic biological effects of statins at a very early stage in their development. And, I think as an immunologist, he probably thought it was inflammatory, all of its effects, reducing inflammatory, but it doesn't appear from the data that you've shown, and I'm just using one marker, which might be viral load, that there was any heterogeneity in the effect by viral load, which arguably could be a marker of chronic inflammation, or a cause of chronic inflammation, I would say. So can you tell us your thoughts based on what's coming out of Udo Hoffman's labs and other places from all this around what is explaining that variability in the projected effect that you would expect from LDL lowering and the substantial benefit of statins in this low-risk population?
It's an excellent question. And we are in the process, Reprieve is in the process of analyzing an array of proteomic data and other biomarkers in the follow-up set of participants, so we can ask and answer the question around what's changed in this group, because it is the heart of the question. To the point about viral load being undetectable in most people and the chronic inflammation, what we've learned is that even in undetectable viral load, there are HIV reservoirs throughout the body, within the bone marrow, the brain even, and other reservoirs that are sequestered from the immune system. But that we certainly know that in people with undetectable viral load, they have higher levels of IL-6 and hsCRP and some of these other inflammatory markers, so that there is some inflammation going on. One of the lines of investigation that we've actually presented at the CROI meeting last year is a pathway that involves the P-Colcy pathway, which is a collagen deposition pathway. I didn't show those data here, although they've been published in abstract form, where when we look at the mediating effect of pitavastatin on the non-calcified plaque is actually the collagen deposition pathway that is most affected by pitavastatin. And so that took us back to some of the other literature looking at other statins and collagen deposition. And we certainly have seen that it was one of the early mechanisms that people thought statins worked through. So I think what we're learning in Reprieve, and we're still learning a lot, is that inflammation's important, but it's not the only sort of player on the scene. And it looks like collagen deposition is impacted by exposure to statins, which then stabilizes plaque.
That was kind of my question. So there's two things I was going to say. One is that, because I thought I was going to follow Larry, that my question is much less reflective and probing than his, which is typical. And Eric probably doesn't know this, but he has a habit of asking a question that I'm going to ask right before I ask the question. So we had that again. And I was just going to mention, I mean, it sounds very much, I should have said, I wanted to start by saying congratulations on this heroic work. It's unbelievable, and I'm so impressed. The story you told about statin and having a greater effect than expected for the ASCVD burden and for the level of cholesterol reduction really does sound like the pleiotropic effects of statin that we've all been chasing for years. And I obviously, with my bias, assumed that it was an anti-inflammatory effect. I didn't see any inflammatory biomarkers on your, sort of panel of patient characteristics. And I wondered, even as simple as CRP, but cytokine levels, et cetera, et cetera.
Yes, and I can certainly share those data with you. We've certainly reported on them. We did not see a significant change in hsCRP and IL-6, and there are a number of others that I'm sure we've investigated. But we were also struck that, 2 years of pretty consistent adherence with a moderate intensity statin in this population, we were expecting that we'd see more biomarker change. And so far, and I think Dr. Grinspoon would appreciate if I caveat, so far with the biomarkers that we've analyzed, we haven't seen that dramatic reduction in inflammation, but we have seen these other pathways that I think we're uncovering and that we should explore more, particularly in collagen deposition.
Thank you.
Hey, Mary, the last question.
Yeah, also congratulate you for this heroic work. And I have one comment and one question. One is that this is a retrovirus, so it incorporated itself in the genome. So it would be very interesting to know where it is going to be incorporated and what would be that kind of the genetic background that can give you this risk of cardiovascular disease. And the question I have is that, did you compare the treatment that cardiologists initiated to see that they could cause adverse effects? Because they had a visit to the cardiologist, there is something, and then we saw that adverse effect of this intervention. Did you look at that type of intervention that cardiologists did?
Well, I appreciate the comment. Thank you. And for the question, that is analysis that we have actually ongoing currently, because the question is, what is the mechanism, of even within our healthcare system, what is the mechanism by which an encounter with a cardiologist may impact events? So far, our initial signal on sort of our first blush analysis, I think that's confounded by indication to see a cardiologist, but we're actually currently working on use of imaging, use of stress tests, looking at lab work in terms of, BNP, ordering LP(a), like looking at sort of the care paradigm in the two different environments to see if that affects outcomes. So TBD.
Thanks, Jerry.
Thank you. Mike, how's it going, man? Great to see you. Good to see you.